colleagues and everyone who joined. My name is Zita Weise-Prinze from WHO, and it is a pleasure to welcome you all to this webinar on the recently released management section of our guideline for the prevention and management of wasting and nutritional edema. This will only be an introductory session covering the management recommendations and good practice statements, and is only the beginning of the rollout of the guideline. We will have the official launch of the complete guideline later in the year, when we will publish both the management and the prevention sections in the full guideline. We have 90 minutes where we will be sharing with you the overview of the new guideline. And this will be followed by a Q&A, a question and answer session and discussion before we close. And please do feel free to start sending your questions on the Q&A box. Now some housekeeping points, which is on the next slide. Please, as mentioned, use the Q&A box at the bottom of the screen for the questions and not the chat box. The questions that come in the Q&A box will be answered by panelists during the discussion at the end of the presentations. For information in today's webinar, we will have a simultaneous interpretation in 3 languages, in Arabic, in French, and in Spanish. So if you would like to listen to the presentation in either of these languages, please click on the interpretation button at the bottom right hand of your screen. You see this on the slide. And also for information, the session is being recorded and will be made available to all of you at a later stage. This webinar was organized jointly, so slide 3, please. You can go to the next slide. Was organized jointly by the Global Nutrition Cluster Technical Alliance and by WHO and UNICEF. In this slide, you will see the logos of all the member organizations of the webinar working group, as well as our donors, without whom we would not be able to deliver this webinar. Now, just to introduce colleagues on this webinar today, we have from WHO, we have Jaden Benda, Alison Daniel, Kirli de Polne, and myself. And from UNICEF, Grania Maloney, Min Tram, and Grace Fonnell. So with this, let me get started on the main presentation of the guideline with the objectives. The objectives is really to give a brief introduction on the scope of the guideline, the guiding principles, and an overview of the main recommendations and good practice statements, and to give you information on the next steps in terms of the development of operational guidance, the research gaps, and the plans around dissemination, country assessments, updates of national protocols and guidelines. Now to some key messages on the management section. The first one is that nutritional status should not be seen in isolation. It's important to assess the infant or child's health when it comes to decision-making. The second is that mothers and their infants less than 6 months at risk of poor growth and development must be identified early on and cared for as an interdependent unit. And effective care for infants and their mothers can be seen as an effective preventative action for preventing infants into deteriorating to severe acute malnutrition. The next key message on the next slide is that not all children with MAM, which is moderate acute malnutrition, need a specially formulated food. The guideline clearly lists the risk factors to prioritize which children with MAM to consider for SFFs are specially formulated foods. These risk factors include high-risk contexts, such as humanitarian crises, as well as specific individual or social factors. The next key message is children with SAM, severe acute malnutrition, should receive nutritional treatment with a RETF, a ready-to-use therapeutic food that meets the Codex specification. And the amount of RETF given can be either constant until recovery or reduced after the child reaches the MAM phase. This depends very much on the capacity and the context. You will hear about this, of course, more when we go through the recommendations. The next key message is that community health workers can manage children with acute malnutrition in the community, children from 6 months to 59 months of age. The important point here is as long as they are adequately trained and receive ongoing supervision and support. The last key message is that the recommendations in this guideline, they give options to consider, which means assessments and consultations need to happen at the country level to identify the best approaches for the specific setting. So those were the 6 key messages. Next slide, please. Just one slide on terminologies for clarity. The WHO guideline document talks about wasting and nutritional edema, moderate wasting or severe wasting and or nutritional edema. Whereas when we develop the operational guidance, we will use the terms MAM and SAM, moderate acute malnutrition, severe acute malnutrition, as has been used by, especially in countries up to now. And just for, if there are more questions about the definitions, please do see there is a section in the guideline on Magic App. Take time to look through this section if you still have questions and need more clarity about definitions. Next slide, please. Now the scope of the 2023 guideline versus the 2013 guideline is that in 2013, the guideline covered the treatment of infants less than 6 months and children from 6 to 59 months with severe acute malnutrition. And now in the current guideline, the 2023 guideline, a broader group of infants are covered, and infants of SAM are a subset of these. So we talk of infants at risk of poor growth and development, which is a broader group. This current guideline also includes children with moderate wasting, which the previous guideline did not include, and the area of prevention, which is a new area for WHO. It has not been looked into in the past. Again, the scope of the guideline is clearly stated in the guideline document in Magic App, so please have a look in Magic App for further information. Now to guiding principles that have guided the work of the development of the recommendations. The first one is the child health approach. And it's about putting the child's health, growth, and development at the forefront, as I mentioned, as one of the key messages as well, and is to prevent children being siloed into programs. The second is caring for the mother, caregiver, infant pair. The point is that care needs to meet the needs of both the mothers and the caregivers, the mothers or caregivers and the infants, which is vital. And the health and well-being of one is intimately linked to the other. So it's the mother, caregiver, infant pair. Then the multisectoral action with the health system at the center. The health system needs to be central to where children and their families access services for the management of wasting and nutritional edema. However, we have to also be clear that, as reflected in the Global Action Plan for Child Wasting, that the prevention and management of wasting and nutritional edema must involve other systems as well, besides the health system, such as food, water, sanitation, social protection, and for true and sustainable impact. The next guiding principle is nutritious food, home foods as a priority. It's about emphasizing the importance of access to diverse, locally available and nutrient-dense foods that constitute a healthy diet, as integral, of course, for the prevention of wasting, but also for the management of moderate wasting and recovery from severe wasting and/or nutritional edema. The second last guiding principle is gender equity. The promotion of gender equity is central when it comes to the prevention and management of wasting and/or nutritional edema. And the last one is local adaptation. The point here is that implementation of the recommendations should be informed by the local context and is linked to the last key message that I mentioned about the need for country assessments when these recommendations are being implemented or adopted by countries. Again, just to mention that there is a specific section on these guiding principles in the guideline document in Magic App. So you can go back to Magic App if you would like to see this in more detail. What do we mean by a child health approach? This is when a child presents. The important thing is that we get all the services that they need. And we have to work together to support the services which work around the child, rather than try to fit children and their families into programs. The child-centered approach is what we should be focusing on and not the program-centered approach. The next slide shows the section of the guideline. There are 4 sections. The A, B, and C are on management. The first is on infants less than 6 months of age at poor risk of growth and development. The second is infants, children, older infants above 6 months up to 59 months of age with wasting and/or nutritional edema. Then the management of that age group. C is about post-exit interventions after recovery from wasting and/or nutritional edema. And the last, the D, is on prevention. So we will today be presenting on A, B, and C, which constitutes the management section. The last slide that I will be presenting is just to make the plea to all of you to read the remarks. The remarks in a WHO guideline are there really to help you all interpret the recommendation or the good practice statement, and there are also elements that would be important for the implementation, especially now before the operational guidance documents are out. So do have a look at the remarks. I will now hand over to Alison to present section A on the infants at risk of poor growth and development. Over to you, Alison.
Thanks very much, Zita, and hello to everyone online. This is a fantastic turnout. Next slide, please. So as Zita talked about, the 2013 guideline update included a limited number of recommendations for infants that were less than 6 months of age with severe wasting and/or nutritional edema. But building on this, a key aim for this new 2023 guideline was to produce guidance on identification and appropriate interventions for infants less than 6 months who are not growing well, really with a preventative lens before they meet criteria for wasting and/or nutritional edema. And just a note about other guidance that exists. There are a number of current WHO guidelines that focus on infants up to 6 weeks of age or in the neonatal period. And there are also some IMCI recommendations and guidance on infants up to 2 months of age. However, we do know that there is a key care gap between following the neonatal period and up to 6 months of age in infants at risk of poor growth and development, which, as Zita also said, includes but is not limited to infants with severe wasting and/or edema. So the guideline development group for this guideline spent a significant amount of time coming up with criteria for identifying infants who are at risk of poor growth and development. And I do want to just stress that this is not a definition, but these are criteria to determine that these infants might need additional support. So the first category of criteria is infants with poor growth based on sequential measures, which is an ideal scenario in which you can look at multiple time points and determine, for example, if infants are not gaining weight or if they are experiencing weight loss. Now, on the bottom there is another scenario in which infants can be identified based on a single measure if sequential measures are not available. Based on different cutoffs, including MUAC below 110 millimeters for infants 6 weeks to 6 months, weight for age Z scores below -2, weight for length Z scores below -2, or nutritional edema. Then on the left-hand side, there's also a category of infants at risk due to poor birth outcomes, and these were informed by prognostic evidence. And these criteria include low birth weight, small for gestational age, and preterm birth. Then on the right-hand side of this figure is infants with known risk factors for poor growth and development, which can include neurodevelopmental concerns, for example. Next slide, please. So I'll just give a very brief overview of the recommendations and good practice statements for this particular population group. And again, that is in part A of the guideline. I also just want to mention what a good practice statement actually is. So this is an actionable statement that we know to be true, or we know to have benefit for infants at risk of poor growth and development, and do not need trial evidence to know that. So these are really important advocacy statements, and they may highlight needs for practice and so on. So the first good practice statement within this section of the guideline is that mothers or caregivers of infants must receive regular care and monitoring by health professionals. So you also heard Zita talk about the guiding principles and considering the mother-infant-child pair, and this really highlights that message as well. In addition to that, there are recommendations on inpatient admission, outpatient enrollment, and in-depth assessment criteria for determining which pathway an infant should follow. One of the parts I'd like to highlight is this in-depth assessment, which is looking more in detail to determine if infants do require inpatient admission or not. And one of the key points here as well is that medical problems have been outlined for these infants in terms of these criteria, as well as for infants and children above 6 months, which you'll hear Kirli and Jaden talk about later on. Another part of the recommendations here is reducing frequency of follow-up and having a final assessment once infants do reach 6 months of age. Then we also have a good practice statement on comprehensive assessments of breastfeeding and lactation challenges. And addressing these challenges is really at the core of this guideline for this population group. In addition to this, there was an update to the recommendation on supplemental milk types from the 2013 recommendation that was focused on infants with severe wasting and/or nutritional edema. So there is one update to that recommendation in terms of the types. There is also a good practice statement about decisions around when to introduce supplemental milk, again, highlighting breastfeeding as a priority and ensuring that caution is taken when introducing a supplemental milk. And then lastly, there is an additional good practice statement on maternal support for physical and mental health and well-being of mothers and caregivers specifically. So I'll now hand it over to Jaden to speak about the recommendations for severe wasting and nutritional edema.
Thanks so much, Alison. Hi, everyone. So I will give you the recommendations for severe acute malnutrition. But first, I will mention just 2 definitions that we should keep in mind. The first one is that when we talk about specially formulated foods, for example, ready-to-use therapeutic food, so ready-to-use supplementary food or ready-to-use therapeutic food. For mom children, the emphasis is about supplementation, which is to say that these special formulated foods are only meant to supplement the home diet to meet the nutrient requirements for children with mom to recover. And these supplementary foods are not meant to cover all the nutritional needs for the mom children. Therefore, all the time that we're talking about specially formulated foods and children with moderate acute malnutrition, we should talk about nutritional supplementation. While when we go to severe acute malnutrition, we talk about ready-to-use therapeutic food, which is meant to meet all the full nutrition requirements for recovery of children with severe acute malnutrition. Therefore, the word nutritional treatment should be used only when we're talking about RUTF for children with severe acute malnutrition. We have provided these definitions clearly in the glossary of the guideline, and we encourage you all to read carefully on the glossary section. Next slide, please. So moving on to the recommendations. The first one that I want to mention is that the GDG came up with a good practice statement emphasizing the importance of triaging and of comprehensive health assessment for children. And we have a recommendation on admission and discharge criteria. If you remember well, in the 2013 guidelines, there was admission and discharge criteria as well. But the 2013 guideline did not provide the details of the medical problems that would let a clinician decide when to admit a child to inpatient care or to enroll in outpatient care. So in this new guideline, we have provided a detailed list of medical problems that would indicate when a child should be admitted to inpatient care. And just to say that this list was developed based on the evidence from a systematic review on prognostic factors, but we also looked at the existing WHO guidance. And in trying to come up with this list, we have made sure that it's also consistent with existing guidance from other WHO documents. More importantly, IMCI guidance, as well as the pocketbook of hospital care for children. We also have, previous slide. We also have this extra step of in-depth assessment, just like Alison mentioned under the section of infants. For the children 6 months to 59 months, we also have this additional step. And just like in the 2013 recommendations, we have maintained that MUAC, weight for height, and nutritional edema can be used as independent criteria to enroll a child into treatment. And we have detailed these definitions again in the guideline. Another important point that I wanted to mention is that because much of the treatment processes require that we weigh the children, for example, calculating the dose of ready-to-use therapeutic food, calculating different drugs, weight is very important, and that MUAC alone cannot be used to monitor a child's progress through treatment. Therefore, tracking the child weight is really, really important. For exit, there was a long discussion amongst the GDG, and the guideline development group decided that for a child to exit in treatment, the child should no longer have measurements which should meet admission criteria. This is to say that the child can exit treatment if the MUAC is greater than 125, as well as the weight for height is greater than -2, and the child has no nutritional edema. However, the guideline development group also made it clear that we should have a remark acknowledging that sometimes the child can normalize on one criteria, and while the other criteria hasn't normalized even after prolonged treatment. So in such cases, the clinical team should make a judgment and assess if it is safe for the child to exit from treatment. But an appointment has to be made for follow-up within a month to check if the child hasn't deteriorated. So these criteria are for standard protocol, and WHO acknowledges that in emergency context, some adaptations may need to be made to ensure that the children receive appropriate care. But plans should always be put in place to go back to the standard protocol as soon as possible. On assessment of dehydration, the Guideline Development Group also came up with a good practice statement, which was meant to emphasize that existing tools should be used to identify dehydration and to decide when to provide hydration fluids. And to be able to do this assessment, clinical staff need to receive specific training and ongoing supervision. In terms of rehydration fluids, the Guideline Development Group made a recommendation or sustained the recommendation from 2013 that Resomel is the preferred solution for rehydration in children with SAM and dehydration. But when Resomel is not available, ORS can also be used for children with SAM and dehydration. And when it comes to hydrolyzed milks, the Guideline Development Group concluded that there was insufficient evidence to recommend switching to hydrolyzed formulas in children with SAM who are not tolerating therapeutic milks such as F100 or F75. And finally, the quantity of RUTF, the recommendation that was made was that for children with SAM who are enrolled in outpatient care should receive a quantity of RUTF that will provide 150 to 185 kilocalories per kilo per day until the child recovers from acute malnutrition. So this is one option that was provided. The other option is that you can start by providing 150 to 185 kilocalories per day until the child is no longer severely wasted and does not have nutritional edema. That means the child has reached a definition of moderate wasting. And then after that, you can decide to reduce the quantity to 100 to 130 kilocalories per kilo per day until anthropometric recovery. Just to say that in the 2013 recommendations, the quantity of RUTF was 150 to 220 kilocalories per kilo per day. And then the decision to reduce this quantity of RUTF as option B should be made taking into account the capacity of health workers to be able to deliver these changes safely and efficiently. And also in terms of food security context, where there is widespread food insecurity, that maybe reducing the quantity is not appropriate, especially if there are concerns about intra-household sharing. So these decisions have to be made at a programmatic level and with all the considerations taken into account. So in brief, these are the specific recommendations for SAM. I will now pass on to Kiri to present on infants and children with moderate acute malnutrition. Thanks, and over to you, Kiri.
Thanks so much, Jaden, and good morning, good evening, everybody. So next, I'm going to be taking you through a very brief introduction on the recommendations and good practice statements for MAM. Exciting times for WHO. There's been guidance before, but not specific recommendations. So to give you a big picture, we're starting with our main 3 priorities for MAM, and that is the importance of assessing and treating medical problems. We also want to talk about the importance of accessing nutrient-dense home diet for healthy growth and development. And only when that's not possible are we talking about accessing appropriate specially formulated foods, or these SFFs. Next slide, please. So this is a long list. I'm going to take you through it one by one. And these are sort of the summary and the principles as well that are behind all these MAM recommendations. So our first very important recommendation, Zita's already said this to you earlier, is that not all children with MAM need a specially formulated food to supplement their diet. And I think this comes from, well, from the evidence, but also we've all seen over the years that children with MAM can be a child who really is about to fall into SAM to a child who's just fallen into MAM from being unwell, for example. So we see such a wide physiological basis for these children. And so it's really important to understand that not all of these children need a product. However, all children with MAM need a health assessment to rule out a medical problem that could be the cause or the main driver of the MAM. Perhaps if that is addressed, the child is no longer going to be MAM. So it's very important to look at that. And that we also know that all children with MAM need access to a nutrient-dense home diet to meet their energetic and nutrient needs. Some children with MAM have risk factors which make them more likely to die or to not recover from others. Now, these risk factors were generated from a prognostic factors systematic review that was carried out as part of this development, the guideline development process. And then these risk factors are related to whether they live in a high-risk context, such as a humanitarian crisis, as well as specific individual to that child, or social factors, which can be a mixture of individual and contextual factors. And then next, these factors can be used to consider which children with MAM should be prioritized to receive specially formulated foods to supplement their home diet. Again, just like Jaden was saying, supplementing their diet. And this really speaks to, for many years, we've been wondering, well, which are the children we should be prioritizing? And this very much isn't saying that children with these risk factors should receive these products. We're saying that if you need to have a way to prioritize who should get them, these are risk factors that you can look into. It's important to note that we don't have the next step of the research, which is, and then you give these specially formulated foods and that decreases their risk. That we hope is coming. But what we have now is a medical logic of children who are at higher risk of mortality and not recovering are going to be the children that you would decide to prioritize. Now, when we talk about these specially formulated foods, they can be RUTF, RUSF, or an improved fortified blended food. One example of that would be Super Cereal Plus. So that's very important. I'm going to say that again. Specially formulated food can be a lipid nutrient supplement which meets the technical specifications of RUTF or RUSF, or an improved fortified blended food. Now, it's important to note, just referring back to the SAM here, that we are saying you can use RUTF to supplement children with MAM. However, you cannot use RUSF in the current guidance to treat SAM. These recommendations also do not include the use of SQLNS to supplement MAM. And also, just to say that we see the children who start as SAM and become MAM are different to the children who present for the first time as MAM. So children who start as SAM and are being treated are recommended to stay on RUTF until they reach anthropometric recovery, even if there is a decision, as Jaden said before, to reduce the amount. We also know that all children 6 to 59 months with MAM need 100 to 130 kilocalories per kilogram per day to recover from MAM. And just to give you the comparison, children of a similar age, 6 to 59 months, who are non-malnourished need 80. So you can see there's an increase in their needs. Now, this figure came from a work that the GDG did with WHO on looking at existing energy needs and protein needs from WHO and FAO, combined with some data from the chain studies on resting energy expenditure, and then combined with considerations for children with morbidities. And then this is the figure that it's come up to. Now, if you decide to give a specially formulated food to a child with MAM, it's then been recommended that 40 to 60% of their total energy needs should be covered by that specially formulated food. And again, that came from the trial data of how much they were giving the children in the trials. Next slide, please. So I know it's a lot to take in, and it will take all of us a time to digest these recommendations, but there are a few key points again. We are not treating MAM. We need to shift our language, our policies, and our protocols. we are supplementing MAM. And we are supplementing only 40 to 60% of the child's needs when we're using a specially formulated food. So we must ensure that the other 40, 60% is covered. This is vital. And the most sustainable approach to that is local home foods. And that's when we're working really closely with our GAP partners and our GAP UN agencies about trying to work out how best for these families to access that food. Next slide. So what advice can we give for a nutrient-dense home diet? Well, we still believe that compared to where we've been in the past, we're a little bit ahead now. So we know we've got this total daily energy requirements for MAM that we can work on. We've got the nutrient requirements from the MAM technical note. Some of this is going to need some refining, considering different proportions were looked at in 2012. But then we need to do the next step of the work for our operational guidance. Do we plug all that into NUTVAL? Do we use other programs? Are we going to look up some local recipes, some food rations? So all of this is the next step of really exciting work to work out how can we give really important food options to children with MAM to make up this other proportion of the diet which needs to supplement the children who need specially formulated foods, and overall for children with MAM to be able to access these nutrient-dense diets that's so important for their growth and development. Next slide, please. So I'm going to keep talking to you. I'm afraid I'll bore you a bit longer for the next section of section B, which is on the infants and children 6 to 59 months, and that's the management by community health workers. So again, quite a big shift for WHO recommendations, which up until now only focused on community health workers screening and referring these children to health facilities. Next slide, please. So this is the text from the recommendation itself. And what we've put in red here is the really, really important aspects. So we said that assessment, classification and treatment or referral of infants and children 6 to 59 months of age with wasting and or nutritional edema can be carried out by community health workers as long as they receive adequate training and regular supervision of their work is built into service delivery. So this is why this is a conditional recommendation. If you don't have that adequate training and supervision, you shouldn't allow community health workers to be managing MAM or SAM. There are big patient safety elements here we must take into consideration. The evidence used for the GDG to make this recommendations was based on studies where there was very close supervision and training from non-governmental organizations. And so to be able to implement this recommendation, we are trying to recreate those conditions. And that's why it's so vital that we have this supervision and this training, and that it is ongoing. It's not one-off training and off you go. No, it's really supporting these community health workers. Next, we know that nutritional supplementation for MAM and nutritional treatment for SAM, as it has been since 1999 in WHO guidance, is kilocalories per kilogram per day. What does that mean? That means community health workers for the standard protocols need to weigh children. We know that that can be very challenging for many community health workers in many contexts. We are already working with our UNICEF partners in the supply division and the innovation unit to look at innovative ways of trying to weigh children of different types of scales. We're trying to do that work because we also know that a real fundamental of any healthcare for children in any part of the world is weighing children. This is really, really vital. And so we know that this recommendation is going to take a lot of work to make it feasible to implement in many, many countries. We know that community health worker networks can be very different from one country to another. And so there's going to have to be a lot of country assessment about what is possible and what is not possible. And that UNICEF and WHO will be there to support countries with that. And the other aspect that you'll see very strongly in the remarks is that community health workers must be adequately remunerated. Next slide, please. Now I'm going to pass over to Alison again to talk about the post-exit interventions.
Thanks very much, Kirli. Next slide, please. So just to start off with the reasoning behind looking at post-exit interventions, we do know that many children who recover from wasting and or nutritional edema have a high risk of relapse and in some cases mortality. So this was something that was prioritized by the guideline development group to look at interventions that could be done after exit from nutritional management. This section starts off with a good practice statement around reinforcing the importance of a comprehensive approach to post-exit interventions that could include counseling and education, support to provide responsive care, as well as safe wash interventions. Now, the systematic review for this question really cast its net wide to look at any types of interventions that improved outcomes post-exit. And the two that came up and that the GDG ended up recommending are psychosocial stimulation as well as potential for cash transfers. So psychosocial stimulation should be started during treatment or management of wasting. And this recommendation also emphasizes that it should continue after exit. Cash transfers are also an option for children who are admitted or enrolled with severe wasting and or nutritional edema to decrease the risk of relapse. However, this is highly dependent on the feasibility and cost. So many of these recommendations in this guideline are conditional, meaning that they might depend on the context and require local adaptation to make sure that these can be rolled out effectively. Next slide, please. So as I think you're all aware, we have published the first part of the guideline on Magic App with a full official PDF to be coming later that includes the prevention recommendations as well. But I just wanted to show you here what Magic App looks like. So you can see an example of one of the recommendations there on ready-to-use therapeutic food for severe wasting and or nutritional edema, which is numbered B10. And you can see that it's a conditional recommendation with low certainty evidence. So all of the recommendations here are either strong or conditional, and then have a point about the certainty of the evidence. And then below the recommendations, you'll see detailed remarks. So Zita mentioned at the start how important it is to look at these remarks, and I'd like to re-emphasize that. The guideline development group spent a considerable amount of time on these remarks, so please do take a look at those when looking at any of the recommendations. Then on the left-hand side where it says sections, you'll see that there are new and updated recommendations and good practice statements that we went through today. And then number 5 there, section number 5 shows standing WHO recommendations and best practice statements that relate to wasting and edema. So please also take a look at those. So I'll now hand it over to you, Tram.
Thanks, Alison, and hi, everyone. So first, thank you to our WHO colleagues for this introduction of the management section of the new guideline. And so we're looking forward for more in-depth presentations that are going to happen later this year once the full guideline will be released. So in the last few minutes of this presentation, I'm going to introduce what the next steps are going to be regarding how to operationalize those recommendations, and as well some words on the research agenda for child wasting. Next slide, please. So first, we're looking at developing an operational guidance that will be adapted to our audience. So for example, we'll have policy brief and advocacy materials and tools for policy makers. We'll have guidance on, for example, setting up and running services and monitoring quality for program managers. And then for healthcare workers, we'll have updated technical modules, we'll have training tools, clinical decision-making tools as an example. So in each context, we're going to assess what recommendations from the new guidelines are feasible and relevant and how to implement them and make them practical. So guidance will be made relevant for member states and partners and regional, at national and district level. So a lot of the questions asked in this webinar are going to be really useful for us as well to develop that. Next slide, please. So here you have an example of a structure that we're going to use for the operational guidance for health workers. So as you can see, it's divided into the main section of the new guideline. So we have inpatient, management of MAM, management of SAM, management of infants. We're going to have the prevention section to come. So we're going to ensure that those new practices are integrated into some of the WHO health guidance. So for example, we're going to make sure that the manuals for IMCI, ICCM, the WHO pocketbook for hospital management are updated using those new recommendations. Next slide, please. And so in addition, identifying research priorities will also be part of the next steps. So along with the provision of guidance on the important aspect on how to design research protocols. So many research gaps were highlighting during the guidelines development process, and it will be a good starting point for us for our future research agenda for wasting. So we'll also want to support partners in designing robust research protocols, allowing future reviews by WHO guidelines development groups. Next slide, please. And so to do all of this, UNICEF and WHO, we have set up an official technical advisory group, the TAG, which is made of 19 core members and some additional observers. Some of our UNICEF and WHO colleagues at headquarters, regional and country level are part of our TAG secretariat, and they're providing guidance on the directions of travel. So we have ensured that key voices from global, regional, and country level across the globe are represented through our membership. And this group will support the review of the operational guidance. They will review the research agenda and other vital work streams. So we already have sub-working groups set up. So for example, we have one on under 6 months, one on SAM, one on MAM research. We have nutrition in emergency. We have the CHWs, definition and terminologies. So in terms of timeline, we're hoping that the manual for health workers will be ready by the end of this year. And we're looking at having updated training packages for inpatient and outpatient management next year. So you can find more information. So for example, the terms of reference for this group, and then the complete membership and WHO website. Next slide, please. So in addition, we wanted to remind you that key updates are posted on childwasting.org website. So this is our main website for the Global Action Plan on Child Wasting. So more specifically, if you look at the guidance tab, you can find the link to Magic App with the WHO guideline and to WHO briefing notes. So you have two for now. So one is the summary of the new guideline, and another one that was just posted yesterday is on the relation between WHO new recommendations and the simplified approaches package of interventions. So in terms of key updates, we'll continue to post on this website. You'll have WHO processes, but also the UNICEF and WHO tag. So do have a look. And then next slide. Thank you. And finally, our next steps will be to support governments and countries in adapting, updating, and integrating the relevant new recommendations and operational guidance into their health and nutrition plans, policies, and protocols. So this is one of our UNICEF and WHO Nutrition for Growth commitments. And this will be done in close collaboration with our partners, including the one from the Global Action Plan. So this is FAO, WFP, and UNHCR, and beyond, and with regional and country level key stakeholders to develop context-specific guidance. And then next, I think this is the end of our presentation. So with this, over to you, Grania, for our Q&A session.
Thank you so much. Well done to all the panelists. I think that was an amazing summary overview of the new guidelines. Now, just to say, we have 8,000 people online. You are in great company. We have maxed out the participation on Zoom. So because we have 1,000 people online, we have nearly 100 questions in the Q&A box. So I wanted to say at this point that we will not be able to address all questions. And instead, I will try and identify questions that are repeated so that the majority of people will be able to hear what they are trying to get clarification on. We will also be sharing the recording after the session, so you will receive that in the coming days. We will not be sharing the PowerPoint at this point. However, there will be a number of webinars in the next 12 months as such, and a number of deeper dives on specific technical issues as the new resources are released that have already been referred to. So I'm going to start. My first question, Zita, will be, could you give an overview of the timeline for the prevention guidelines, given that that's a key part that has come up on these questions? Thank you.
Thank you, Grania. We will be having the guideline development group meeting next week to discuss the questions, the prevention questions, the remaining ones. We then have to get the prevention recommendations cleared within WHO, which will be in September. And hopefully by end of September, beginning of October, we will post them on Magic App together with the management recommendations that are already there. So have the prevention recommendations on Magic App by, as I said, end September, beginning of October. We will also be producing a PDF version of the whole guideline, the management and the prevention sections as a document itself. So we'd have the Magic App version, online version, and the PDF version. This PDF version we hope to be able to have available before the end of the year.
Thank you so much. Thank you, Zita. Now I'm going to start with you, Alison. There was a few questions on some of the methodology. How is this these reviews done? Is that information available? That's the first question. And then we have a number of questions related to identification of poor growth and development in infants under 6 months. How is that done? Are there any changes with the management of severe acute malnutrition in this age group? And what about the role of MUAC in the under 6 weeks and the 6 weeks to 6 months? Over to you, Alison.
Thanks, Grania. You might need to remind me of some of those questions that I answer each one of them. But in terms of the systematic reviews, so for each recommendation, an effectiveness review was done, and a cost effectiveness and resource use review, as well as a qualitative review on equity, acceptability, and feasibility. If you go into Magic App, you can see that there is under each recommendation, there's a section on research evidence where you can actually see the evidence profiles for each respective recommendation. And then there's an evidence to decision tab where you can see the information for each of those different domains that I talked about. So the effectiveness, resource use, cost, equity, acceptability, and feasibility, and also how the guideline development group made judgments on those. In terms of the systematic reviews, we have asked authors of those to go ahead and publish those, and we will be linking to them once we update the prevention recommendations in Magic App as well. So hopefully those will be available to you soon as they're published. So I think the next question was on the criteria for infants at risk of poor growth and development.
Yes, and also on severe acute malnutrition as well.
Yeah. Yeah, so I want to emphasize again that these are criteria. This is not a definition, and we didn't set out to look at which cutoffs best identify children with SAM versus the at risk of poor growth and development. So again, just emphasizing that these are criteria to determine if infants are at risk and if these good practice statements in the guideline apply to these infants. I did also note one other question on neurodevelopmental concerns, and I do want to emphasize that within the bucket of infants with known risk factors for poor growth and development, neurodevelopmental concerns, infant feeding concerns, maternal risk, and history of hospitalization are all included. So we did try to encompass a wide group of infants that could benefit from these good practice statements, but didn't go as far as determining specific cutoffs for SAM, for example. In terms of what's new since 2013, there's one recommendation on the types of supplemental milks for infants under 6 months with severe wasting and/or nutritional edema. And there's one update made to that recommendation. So the recommendation starts by emphasizing the importance of breastfeeding and aims of reestablishing breastfeeding, and then outlines different scenarios in which a supplemental milk might be introduced. And there is one update around giving undiluted F100. So in the previous recommendation, it said never to do that for these infants. And now it says, please be careful about doing that and only in certain circumstances give undiluted F100. So I encourage you to look at the exact wording of that and check on the detail of that recommendation. But that's the only updates to the recommendation since 2013, aside from the numerous good practice statements for this broader population group. Did I miss anything there, Grania?
No, you didn't. But while you're here, I'm seeing quite a few questions coming in on acute malnutrition in pregnant and lactating women. Can you explain why they were not included in this guidelines?
Yeah, I might ask my colleagues Zita and Jaden to comment on that, but I will say that even covering these 4 main topic areas for this guideline, so the infants at risk of poor growth and development, severe wasting and nutritional edema, moderate wasting, and prevention, this was a huge undertaking and a very wide scope, but I'll let Zita and Jaden comment further on that.
Thank you, Alison. Yes, I mean, there are quite a few questions that we couldn't include in this, in these 3 years that it took us to complete this guideline. However, it is an important point. The maternal nutrition is important, and there is a separate process that we are starting together with our antenatal colleagues, and try to feed into the update of the antenatal guidelines. So there is a separate process we're trying to push for and follow, and we do see it as an important area. Thank you.
Thank you so much, Zita. Great, thank you, Alison. So now we're going to move on to Jaden. There were quite a few technical questions on admission criteria. Things like, are we still using the appetite test? How do we know when to move children from inpatient to outpatient? What do we do with non-responders? And then what's the new evidence on the use of ORS when Resomal is not available? So I'm going to hand those over to you, Jaden.
Thanks, Grania. Yes, so in the first one is about admission criteria and appetite test. So yes, this is still one of the indications to admit to inpatient care if a child has a poor appetite or has failed appetite test. If you go to the guideline document itself, recommendation B2A outlines the different conditions that can be used to decide when to admit to inpatient care. But they are in 4 broad categories. One is if there are IMCI danger signs, or there are acute medical problems, or if there is a severe nutritional edema, and the last one is a failed appetite test. But they are all outlined in there. In terms of when to discharge the child from inpatient, first of all, it's transfer the child from inpatient to outpatient care. And the details of when to do that are in section B3A. And just briefly emphasizing that it's when the child no longer has danger signs for at least 24 to 48 hours, and the medical problems that led to the admission have resolved or are resolving, and a few others that I would not go into detail now, but just to encourage you to go in the guideline, and you'll find them all there. The third question, remind me, Grania.
The third question was on non-responders. If children are not responding, what do we do with them?
Yes, so I think this is more of an implementation question, and we are going to look at this type of issues in the technical advice group and provide clear definitions and what to do in those situations when we produce the implementation guidance.
Great. And then if you could explain the evidence behind the recommendation on the use of ORS in the absence of Resomal. And then one final question has just popped in. Can severely acutely malnourished children be vaccinated? Or is there immunity, is there a risk to vaccinate these children? Thank you.
In terms of the evidence that led to the use of ORS, there was one trial that was done in Bangladesh that showed that ORS didn't have negative, or it was performing the same as Resomal. But just to point out also that that in that trial they added potassium to the ORS to make sure that the level of potassium was the same as that for Resomal. But in terms of assessment of safety outcomes, there were no adverse effects for the use of ORS in those children. The vaccination one is a bit tricky one. I don't know if my colleagues have anything about that.
So just on the vaccination, we know that vaccination is one of the most important public health interventions we can possibly do. So yes, we want to make sure that malnourished children get vaccinated, but we also have to take consideration of their clinical state. And so we will be producing operational guidance about when is the safest time to vaccinate those children in terms of inpatient. When they're as inpatients, as outpatients, they should all be vaccinated. And we're working closely with our vaccination colleagues in WHO and UNICEF to make sure that that guidance is clear. But the overall message is vaccinate, 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 and never miss any opportunity. And I think of all our children who are in these services for long periods of time, we have no excuse for not vaccinating them.
Great, thank you so much. I think that was super helpful, both from Kirli and Jayden. Jayden, one final question. Somebody was asking, and this is a question we get often, what about a severely acutely malnourished children that's over 5 years of age? What do we do with that child?
Yes, so this guideline specifically was looking at children up to 5 years of age. But we should also remember that there's the manual from 1999, which we're planning to update. And in that manual, there's the guidance for children over 5 years of age. So when we are updating the manual, I think we'll try to make how to manage these children who are over 5 years of age. But the recommendations for this guideline were specifically for children under 5 years of age.
Thank you, Jayden. And I thought I was done with you, but I do have one final question before we move to Kirli.
Sure.
And that question, and it's repeated in different iterations, and it will also come to you, Kirli. What if children are recovering well, they're growing well, severely acutely malnourished children? Can we replace some of their RUTF with family food before they recover from severe acute malnutrition?
I can start, and maybe Kirli, you can jump in as well. It's a very interesting concept. Just to say that it wasn't one of the questions that was for this guideline. As you can see, we had a lot of questions, 16 questions, a massive amount. So there are some questions that were left out, not because they're not important, but because we just couldn't handle everything. And if we have, WHO is moving towards a living guideline approach where we scope the evidence, and if you find that there's good enough evidence to answer a question, we can convene a guideline development group and look at that question specifically. So if there's evidence out there, we would do the scoping and see if there's evidence there. This could be one of the questions that we can look at for the next to check if we can make a recommendation or not. But for this time around, it wasn't reviewed, so there's no recommendation about the home diets for children with severe acute malnutrition.
Perfect. Thank you so much, Jayden. I think you've brought a lot of clarity there. Now, just to remind participants, we are not taking any questions from the floor, so please post your questions in the Q&A box. We have 1,000 people online, so we would not be able to manage that. Now, Kirli, lots and lots of questions. Let's start with, can you define what a nutrient-dense home diet is? And how can we ensure that these moderately acutely malnourished children can access what they need from that? Over to you.
That's a great question, especially the second part of it. So in the glossary, again, we have defined a nutrient-dense diet. So you can click on the glossary in Magic App and you will see the definition of a nutrient-dense diet. So there has been a lot of work in the past which has gone on, and especially our colleagues at WFP who've looked into this as well in terms of nutrient requirements for children with moderate acute malnutrition. And as I said before, some of that work might need some bit of tweaking now that we have the energy requirements, and now that we know we talk in different proportions perhaps than before, but we do have those nutrient requirements, we do have the energy requirements. So now it's up to us to be really looking at local solutions, to come up with local recipes, local solutions, and try and sort of push the availability of food. That's when we work with our colleagues in FAO to talk about more sustainable long-term approaches. But we are really, really keen. That's a big message that's coming out of these guidelines, is the importance of home foods for children's healthy growth and development. And then in terms of how they access them, well, that's like the 937 people on this call. That's all of our job, and especially those of our colleagues here who are in government positions and our colleagues who are in donor positions. We really want to ensure the access to these foods. We know there are places where this food isn't possible to access on the markets, and perhaps then we need to think about food distribution. But when there are places where these foods can be accessed and people aren't accessing them, then we need to think about ways to help them access. But that's definitely a question that we all need to be thinking about. And what our work is to do is to try and package some of the needs into ways that could be more that could help people sort of come up with sort of practical solutions. And indeed, it may be that we may use micronutrient powders to supplement some of the home diets if we really cannot meet those nutrient needs just from home foods alone. So we need to sort of be a bit creative, and that's the kind of work ahead. And I think there's probably so many people on this webinar even who could be able to contribute to that. And our technical advisory group for sure will be contributing to that.
Thank you, Kirli. I think that's a big challenge and opportunity for all of us to get serious about ensuring these children receive the home diets that they need. But there's questions, if we cannot access that home diet, can we use higher doses of SFFs, specialized fortified foods?
So we have to be very clear about what these guidelines are based on, and that is they're based on evidence and they're based on what's in the trials. So we don't go beyond that scope. We know that when we're in the operational guidance, we can try and be more flexible in presenting maybe other options or case studies people have done. But in these guidance, we are very clear that this isn't supposed to be a nutrition product based guideline. It's all about all the different options. So we are giving the recommendations based on the guideline, based on the evidence that was reviewed. And
Great.
Just to add for that, I mean, that's the thing. One of how the questions were set up is to look at local foods on their own to be able to supplement MAM or to reach MAMs to reach recovery, but that evidence wasn't there. So we have to be really clear about just the overall importance of home diets for children's healthy growth and development. And then that's also linking to the important work going on in WHO on the complementary feeding guidelines. So these things should all be coming together.
Thanks, Kirli. And an important question that came up was the importance of promotion and support to breastfeeding throughout the first 2 years and beyond in the management of these children. It would be good to get your thoughts on that.
So yes, I mean, I think we have a number of good practice statements on those. And just to sort of remind you that good practice statements, our methodologists always say to us, how you should think of a good practice statement is if you're going to jump out of a plane, wear a parachute. So our good practice statements, which talk about the importance of breastfeeding, is because all the evidence is there to say that breastfeeding is so important for children less than 6 months and up to 2 years. And we also then want to be able to use these good practice statements as real advocacy moments, real advocacy for our donors, within governments, within organizations, to really push for supporting these women to breastfeed, mothers, wet nurses. And so that we'll be working on operational guidance also for those sort of small, vulnerable infants to really come up with very detailed guidance on supporting breastfeeding, because it's been such an important aspect. And many of the GDG members have brought this importance to all the discussions.
Thank you, Kirli. Another question was, can medium quantity be used for MAM in the event that there's a lack of ready-to-use therapeutic food or ready-to-use supplementary food?
So again, these guidelines cover the products that are used in the trials. So these guidelines cover large quantity LNS, so IUSF and IUTF. Outside of the guideline process, there is the Global Nutrition Cluster. There is a programming guide on programming in the absence of products. So that can be referred to. It is not a WHO guidance piece, but that is there when there are real difficulties. But for the guideline, we followed what was covered in the trials themselves, and MQLNS for the supplementation of MAM was not covered.
Thank you so much, Kirli. And then there's a whole number of questions around community health workers. In the sense, how can we assume, what do we mean by adequate training? What do we mean by adequate supervision? What happens if there isn't remuneration? Should they have a fixed number of children that they are responsible for? Is there a risk that they're, going to be overwhelmed? So yeah, good to get your reaction on that.
These are all fantastic questions, and they're the questions that have gone around within WHO, within UNICEF, within our guideline development group. And we don't have easy answers, but we know that there's so much interest in this topic and so many great groups working on it. And we also know within WHO, in the Health Workforce Department, they have actually started up a technical advisory group on community health worker curricula. And so Jayden and I feed into that group to make sure that nutrition will be there, because we're very, very aware that in some countries, community health workers are being expected to do something that we pay 5 nurses for in some high resource settings. So we've had an equity lens on developing these guidelines, and we need to keep the spirit of that for the community health workers. So we will be trying to unpack what is adequate training, what is adequate supervision, but we know that that will really look different in every country. So we're not going to be able to come up with a one size fits all and say it's this many weeks or this many sessions, but we will be able to try and give what are the competencies and what would be the sort of a minimum package, and that this can then be adapted per country. But we know that it might be a recommendation that takes quite a few years to be able to implement in some countries, and in other countries ready to go tomorrow. But we really want to make sure that if a community health worker is already screening for TB, doing ICCM, even family planning, that we're not just adding this on as another task that is going to compete against their other tasks. How can we help these community health workers to be able to deliver this really important services really close to these children's homes?
Thank you so much, Kirli. Tram, we've had a couple of questions on the use of simplified approaches and whether they can continue to be used in high-risk areas that are hard to access, and really what is the future? So good to hear from you on that.
Thanks, Grania, and really excellent question, I think. So I think WHO and UNICEF, we do acknowledge that those new recommendations do have an impact on some of the interventions under the simplified approaches. So I'm really making it important to say that the simplified approaches is seen as a package, and then we have all these different interventions. So as you have heard, some of those new recommendations are going to have an impact on that. So this is exactly what the briefing note that I mentioned, which is available on childwasting.org, and it's a joint briefing note between WHO and UNICEF. This is exactly what we've attempted to do, meaning that we have the interventions from the simplified approaches and then how it relates to the new recommendations. So I think that going forward, this is a good basis for us, and we can refer to that for now. And then, yeah, there will be further recommendations, I think, going as we're going to implement the new evidence-based practice.
Great. So I think it's important at this point to remind everyone online, this is just the beginning of probably what will be 1.5 years, 2 years worth of webinars that will delve into different topics on these guidelines. Today is really just the overview. We want to familiarize you all with the key parts that are available online. One colleague did say, does it mean we can move forward and recommend our governments to update their guidelines? Yes, you can. These guidelines are now live. And I'm going to maybe ask Zita on that question. A few colleagues have posted, what are the next steps? How do we support governments to update their guidelines?
Thank you, Grania. Of course, the purpose of the development of these guidelines is really to support countries, support governments, and to update national policies and protocols. So what we are aiming on doing with our partners is really to have local workshops, for example. This is one of the next steps. Get countries together around the table, discuss what are they currently doing, what would need to be changed in their context. So really facilitate these discussions with countries, and so that they know what they would need to update and what they can continue doing. And it's also about capacity building, trainings, and so on. As the operational tools are being developed, but these facilitating these workshops is something that we will start already at the end of this year.
Thanks so much, Zita. And just to say that indeed WHO and UNICEF will be working with the national governments in the countries who are ready to update their guidelines. Our teams are on standby to support, and we will be moving forward in the next 6 to 18 to 24 months to support the governments that are coming forward that want to update their guidelines. And we look forward to all our civil society partners online supporting that process. And I think the key thing is really to work with our national government counterparts to follow their guideline process and to take advantage of the fact that we now have a number of recommendations available and to use that to start the process to update. So we will be moving forward and providing resources and TA at national and at regional level to help that process. Now, Jaden, a couple more questions have come in, quite technical questions on some of the severely acutely malnourished guidelines. One is on, are we using F75 and F100 anymore? Over to you.
Yes, so F75 is still the main therapeutic milk for the children in stabilization phase. And then F100 is used sparingly if children cannot tolerate RUTF, or if the child is an inpatient, but then there's the stockouts of RUTF. I think before I wanted to finish by saying that in this guideline document, there are standing recommendations. So this doesn't necessarily mean that only the 16 recommendations will be moving forward, or the 16 questions, they're the ones that are moving forward. There's still existing recommendations, and F75 is one of the recommendations that has been carried forward as a standing recommendation. So both F75 and F100.
Thank you so much, Jaden. That's very helpful. And then maybe Alison, two questions. One is, did we include the needs of premature infants? Was that included in the review, and how we manage them? And the other question is ongoing research. Can we now start to do trials showing the ongoing work versus the new WHO guidelines? What are your thoughts on those? Thank you.
Yeah, so in terms of the infant section, so section A, the review team did actually look at all infants under 6 months of age, but we didn't know about a soon-to-be released guideline, which is now out on care for the preterm or low birth weight infants. So there are recommendations within that guideline that cover preterm infants, and we've linked to that within the wasting guideline as well. So most of the guidance within the wasting guideline is focused on infants above 1 month of age. But as I said before, we do know that infants at risk of poor birth outcomes, or at risk due to poor birth outcomes, should be covered. And the GDG did highlight that, and that was based on prognostic evidence. So the good practice statements still would apply to those infants. But in terms of the actual recommendations and the systematic reviews, there wasn't much that we could cover beyond what was in that other WHO guideline. So I would advise people to look at that guideline as well. Now, a different question in terms of the research. So the technical advisory group that TRAM talked about has an objective of coming up with research priorities to fill in some of the gaps for the guideline, and to also update some of the recommendations. For example, if a recommendation has low certainty evidence or very low certainty evidence, that might be an impetus to look at new evidence and update that recommendation. The technical advisory group might come up with completely new areas of interest and new recommendations to be made. Now, research should be designed to try and fit within those recommendations and the comparisons of interest, and that's something that the TAG will also be involved in planning and giving guidance around that area. But if Kirli or Tram have other comments on that, please also jump in.
No,
Kirli,
I think you've covered it. I just think it's, we've seen these huge research gaps as we've gone through, and moments when we thought, oh, if there was just an extra arm here or an extra cluster here, or if there'd just been something covering this. And so we'll be doing exactly as Alison said, really trying to sort of consolidate all of that and work on the research agenda. And I think, we all feel that we've achieved something, but there's so much more to do and so much more research that is needed. And so we're really going to be trying to focus on that as well going forward.
Thanks, Kirli. And if I can maybe add, a lot of the questions, and I think they're very fair questions, are about how do we it seems everybody wants to support this agenda of home diets, but it's not easy. There can be a question of, is the food even there? Can people afford it? There's a point about aflatoxin, which is valid. There's a position about, many questions about how do we make this possible. So I think, as you say, we really need to get people to start generating solid evidence and get published, because in the absence of evidence, it's very hard to move forward. So do you have any suggestions for all our listeners today on how to take this question forward, on how to really nail down this issue of nutritious diets at home, and what that means for the future of our programming?
Well, there is actually an exciting study ongoing, which is being coordinated from the Maternal Child Health Unit out of WHO, called NutriMam, which some people on this call may be involved with. And we really hope the results on that are going to be able to help, because that really is specifically looking to using home foods to supplement MAM children and for their recovery. But yeah, so that's ongoing. We hope that will come about. But I think also it's, as ever, we all know, everybody's been working this. This is such a wider question. It's such a multi-sectoral approach. It is really about sort of longer term, how can we also prioritize food for these families? We know sometimes even, aspects of security risk means that people just can't access food. So it's not something we're going to solve overnight, but we know that just as a general message, we have to keep pushing that children need healthy home diets. And there's so much work going on to say what that is, what that means, what that should be, and that's and so then it's for people to try and implement and try and adapt to their context.
Great. There's a question on the distinction between the terms wasting and acute malnutrition. And I think this has been, when we launched the Global Action Plan on Child Wasting a few years ago, wasting became a lot more used and kind of people, it's a shorter term, it's probably easier to understand. But of course, there is a distinction between wasting and acute malnutrition. And perhaps, Kirli, do you want to take that one? Because I know we've been working on giving clarity on those definitions. Thanks.
Sure. I mean, we're all talking about the same thing. That's the main thing. And there is a specific section in the guideline or Magic App called definitions, which takes you through. So in the International Classification of Disease, acute malnutrition is what is used and what is defined. And that is defined by using MUAC, weight for height, and nutritional edema. And then further unpacked into severe and moderate. So the wasting and/or nutritional edema is actually just spelling out what we've been saying in terms of SAM and MAM. And there was a concern that if everybody just keeps saying wasting, that people might think that we're not talking about children who have nutritional edema as well. And that's really, we're not talking about. Everything we are talking about in these guidelines applies to children who have nutritional edema. It's incredibly important. And I think that's because so many of us know that those children are often very vulnerable, often deteriorate quickly. So we really want to push the nutritional edema part because it is so important. And then we also know that for the Sustainable Development Goals, they are based on weight for height only. That's the data that is collected and put towards those. So Sustainable Development Goals are talking about wasting in terms of weight for height. So we just have to be a little bit wary of what is being used where. And that is all laid out in the definition section. And we're just very aware that for many, many countries, they're used to saying MAM and SAM, as I am. And so those are the things that those are the terms that we will use in our operational guidance and in countries, because it's more familiar and sort of less work to change that. Saying that, and we put that in the guideline as well, we acknowledge that there is no perfect terminology. We know this use of the word acute maybe doesn't actually represent what we're talking about. This is often conditions and statuses which develop over a long period, and acute in medical terms means minutes, hours. So there is no perfect terminology. We know that the term malnutrition can also cover obesity and overweight. Undernutrition also incorporates micronutrient deficiencies. So there is no perfect terminology, but the main thing is that we're just clear about who we're talking about and who we're not. And then finally, we know that a lot of this is a bit of a line in the sand. It's a continuum. We know that there are children who would be, come in 1 millimeter or a little bit less of weight for height can be completely differently categorized. And so that's when we rely on our colleagues at the front line who are really doing that clinical assessment of these children to make those decisions. So all of that, just to say that we are also trying to just stick to the language in countries that people are most familiar with.
Thank you so much, Kirli. So my last question will go to Alison, and this is about maternal mental health and the mother-baby pair and the mammy care pathway. Have all of these issues been considered in these guidelines? Thank you.
Yeah, definitely. So there was a systematic review done for this guideline that just looked at maternal directed interventions and their impact on infant outcomes. So it was a little bit narrow in scope in the sense that it was focused on how that impacted the infant. However, we felt that this was very important to consider the mother's own mental health and well-being, and did include a good practice statement on this in the guideline. And as Zita said before, it's part of the guiding principles, considering the mother, infant, child pair, and also focusing on the maternal health and well-being. So definitely that's a key thread throughout the whole guideline.
Thank you so much. So with that, I think we're going to wrap up. I would like to congratulate the amazing team at WHO and everybody who supported them in getting to this stage. I think given the guidelines were only released 2 weeks ago, to come out and have this webinar and answer all these questions was wonderful. So well-deserved leave, as one of the participants said online. To everyone online, thank you so much for joining us. 1,000 people joined, over 2,000 people registered. So we're so grateful that you all came and are excited and enthusiastic and are committed to this agenda. You will, over the next year and a half, there will be a lot more webinars, and there will be a lot more at regional level and at country level. They'll be with your country teams. There will be a lot more resources available. This is just the beginning. So please get involved. Contact your WHO and UNICEF country counterparts if you have any more questions. We all want to work together with our governments to make sure that the children that need help get the care that they need based on the latest evidence. We will be sending out the recording. It will come out to you very soon. And please take time, go onto the Magic app, read the information. There's a lot of information there. There's a huge amount of work that's gone in there. Many of the questions that you asked may well be answered there, so please take the time. And then, of course, read the summary brief and then the note on the simplified approaches. And with that, I would like to thank everybody who has helped in today's webinar, the GNC team, all of our amazing interpreters moving between many different voices and accents. And to all of you, have a great rest of week. Thank you and goodbye.